Hi, I'm Michael Marachna. I'm a family medicine physician in Valparaiso, Indiana. I'm going to talk about prostate cancer and really about prostate cancer screening. We care about prostate cancer because men have a 3% chance of dying of prostate cancer. What's also important to note is that about half of 70-year-old men have prostate cancer. Half of men at age 70 have prostate cancer, but men only have a 3% chance of dying from prostate cancer. This helps lay the foundation for this discussion. Before we move further, I also want to emphasize 2 points. Not all cancer kills, not all prostate cancer kills. This is clear. When we first hear the word cancer, it is common to immediately think about when cancer is going to kill us, not if, but when. It's crucial to remember that not all prostate cancer kills. Here are some prostate cancer screening guidelines. The American Cancer Society, traditionally a very aggressive cancer screening organization, has changed their recommendation to state that patients should have a conversation with their doctor, and they go no further than that. My governing college, the American Academy of Family Physicians, recommends against prostate cancer screening. The USPSTF, a government-funded but not controlled group of primary care physicians, public health personnel, and statisticians, recommend against prostate cancer screening. The American Urological Association recommends screening at age 40 with the prostate-specific antigen test, or PSA, as well as the digital rectal exam, also known as the DRE. Why is there a difference? Let me explain. Remember those numbers? 3% risk of death. Half of 70-year-old men have prostate cancer. Let's look at 3 curves: the prostate, PSA, and cancer over time. All the curves look about the same. They're not exactly the same as they're depicted here, but ballpark idea, they're about the same. We know they all go up over time. The prostate gets bigger in size as we age, and that's why men have to urinate at night, have a weak stream, or feel they cannot completely empty their bladder. We also know that PSA goes up over time. Finally, we know that prostate cancer goes up with age. As we get older, we are more likely to have prostate cancer. We have been checking PSAs commonly over the last 20 years or so to screen for prostate cancer, so let's do that. Before we go further though, let's chat about the actual PSA test. If we check the PSA of 100 men over the age of 50, according to the CDC, 85 will be normal, while 15 will be abnormal. Of the 15 that are abnormal, only 3 will be positive for cancer. It's important to know men with a normal PSA may have cancer, and a man with an elevated PSA may not actually have cancer at all. Now back to the curves. So let's say you have a PSA that is checked and is considered high, as you can see represented as a star on the graph. What then? A urologist can look at several things. They can look at the different types of PSA, such as free versus bound PSA, as well as the total. They can look at PSA velocity, which is watching the change over time in the PSA number. They can also calculate a PSA density by dividing the PSA total by the size of the prostate. Family history, a person's ethnicity, previous biopsy history, and age are important too. No matter what, a high PSA alone does not diagnose cancer. If concern is high enough, though, a prostate biopsy will be done. Prostate biopsies are a serious procedure. It involves an ultrasound probe inserted into the rectum where a needle passes through the wall of the colon into the prostate about 10 to 16 times to obtain the biopsies. The procedure itself may result in hospitalization anywhere from 0.5 to 3.4% of the time. Usually this is due to a condition called sepsis or an infection. If from the biopsy it's determined that there is cancer, the first question to ask is whether the cancer will kill me or not. To help figure this out, a Gleason score is calculated based on the biopsies to assess the grade of the cancer. Some patients are then offered watchful waiting, which has been later changed or more recently changed to active surveillance because watchful waiting is a passive term and active surveillance sounds more aggressive and active. Other patients are offered treatment. Treatments range from surgery to chemo or hormonal therapy, as well as radiation. For patients who select active surveillance, we know from research that even if their urologist feels their cancer isn't lethal and recommends active surveillance, about 90% of men eventually proceed to early treatment. So since we're talking about treatment, let's talk about the treatment harms first. Unfortunately, the harms are guaranteed. 5 in 1,000 men treated for prostate cancer will die. About 10 to 70 men out of 1,000 will have serious complications and live. About 20 to 30% of men will have incontinence, impotence, or bowel dysfunction such as diarrhea due to treatment. So let's talk about the benefits. Even more unfortunately, we do not know if treatment results in benefit. The best study we have of prostate cancer screening in favor of screening was a recently released study called the ERSPC. It told us that 1,410 men have to be screened for prostate cancer over 10 years. 48 men have to be treated for prostate cancer to have one survive prostate cancer from treatment. The trial suggested that screening resulted in a 20% decrease in the risk of prostate cancer death. But remember, 20% sounds like a big number, but is 20% of that 3% risk of death that I mentioned. So that's really only 0.6%. Additionally, the two groups in the study, screened versus not screened, died at the same rate. So the group screened for prostate cancer died of a little less prostate cancer, but were a little more likely to die of other causes, so that the overall rate of death between groups was the same. So we are left with arguments for both sides. Proponents of PSA testing remind us that PSA studies are not great studies. They usually are a study of more screening versus less screening. As I mentioned earlier, around 1992, mass PSA screening started without formally being studied first. This unfortunately led to studies being contaminated and resulted in those studies usually being a study of more screening versus less screening, rather than appropriately studying screening versus no screening. Urologists, the doctors who operated on the prostate, tell us that the studies aren't long enough. Current studies have measured around 7 to 10 years of follow-up. Urologists think if we follow the benefit of PSA for approximately 15 years, we'd see a much bigger benefit. They also correctly argue that death rates since we started checking PSA are down. There has been a 30% decrease in prostate cancer deaths since PSA started becoming popular. Unfortunately, correlation is not causation. Our treatments are also better now too. Without a proper study, we cannot attribute PSA testing to the lower prostate cancer mortality or rate of death. Urologists will also say that they trust their eyes. They are the docs in the trenches treating these patients, and they know what works. Advocates against this would argue that trials and evidence are what should guide us, not anecdotal. I know this works because I see it evidence. Pro-PSA advocates also suggest that we should definitely screen African Americans who are at higher risk for prostate cancer, as well as those with a family history of prostate cancer. We don't have evidence that this strategy would be beneficial, so if we did this, we would be exposing those individuals to the harms I mentioned, but also we have no known benefits. The anti-PSA arguments really start and end with two facts. We do not have evidence that this saves lives. And secondly, we know we are hurting men. Overdiagnosis is a concept where we diagnose a person with a condition that they do not benefit from knowing they have. It does not improve their lives, and it may only hurt them. Overtreatment would be the treatment of a condition that does not benefit the patient and only leaves them open to harms. In this instance, this would be treating men for prostate cancer that never would have hurt them, and by treating them, we're only exposing them to harms. Currently, this involves the majority, if not all, prostate cancers currently treated. In that major study I cited, the ERSPC trial, 48 men had to be treated for cancer for possibly one man to benefit. That is a great degree of overtreatment. Finally, Dr. Richard Ablin, the creator of the PSA, has stated that PSA has become a public health disaster. As a quick aside, if we cannot achieve much with screening, can we prevent prostate cancer with medication? The answer is no. Vitamin E has recently been studied, and it shows that it increases the risk of prostate cancer by 1.6 cases for every 100 men who take vitamin E over 10 years. Two medications that are used to treat enlarged prostate due to steroid and finasteride have been studied, and they decrease prostate cancer overall, but they also increase the risk of high-grade prostate cancer, which clearly is not what we want to do. After all of this, it would be easy to be confused. This is the bottom line. No trials demonstrably show that PSA testing saves lives. Anecdotal evidence suggests benefit of PSA testing, and we do know that there has been a decrease in prostate cancer death by 30% since the start of PSA testing. Again, this does not demonstrate, though, that PSA testing saves lives. Trials of PSA screening and prostate cancer treatment show definite and significant harms, including death. There is no medication currently to prevent prostate cancer. A healthy lifestyle may be our best bet, which includes no tobacco, 5 servings of fruits and vegetables a day, 15 minutes of activity a day, and a healthy weight. Bottom line, you should talk about this with your doctor. I'm Michael Marachna. I have 2 offices in Valparaiso, Indiana, and the numbers to those offices are listed below. Thank you for your time.